Welcome to the all viewers and well-wishers of the world. The purpose of my lecture is learn the knowledge from the word, return the knowledge to the word. Motto of my life is learn, earn and return. I have learned a lot, earned a lot, now to return a lot to the world. The topic of today is herpes zoster, which is also called shingles. So the introduction of the disease is shingles or zoster or herpes zoster or zona. These are the other name of the same disease. It's a localized disease caused by varicella zoster virus, DNA virus. It causes neurocutaneous viral infection, means involves the nerves and the skin, with a unilateral painful skin rash with blisters on neck and shoulder mostly. Frequency is about 33% in one's life at some point of the life. Duration is 2 to 4 weeks, and the risk factors are old age, poor immune function, history of the chicken pox before 18 months of age. And complications are meningitis, facial nerve palsy, keratitis, and post-herpetic neuralgia. Diagnostic methods are based on the symptoms, which are very classical for this disease, and differential diagnosis is herpes simplex, chest pain, insect bites, and the cutaneous leishmaniasis. Medications are mostly acyclovir if given early, and the pain medication for the symptomatic treatment. Prevention is by shingle vaccine, which is available now. Now, here one can see the shingles or herpes zoster, these kind of the rash one can see. These are the feature of the rash with the blister and having the fluid, and this is mostly the classical side on which one can see, and this is the lesion, how it presents with the rash and the blisters. These are just the hallmark of this disease. Now, history and etymology. The disease has been recognized since ancient times, initially named by Hippocrates. Herpes means to creep, and zoster means girdle in Greek language. Characteristic belt-like dermatomal rash. According to the nerve dermatome, the rash just appears as that, so it is called dermatomal rash. The name shingles derives from the Latin singulus, meaning girdle. Varicella zoster virus was finally isolated in 1952 by a Harvard microbiologist, and he was awarded the Nobel Prize for this also. Finally sequenced in 1986, and genome size is 125 kbp, long and short fragments with a total of 4 isometric forms. Varicella vaccine introduced in 1995 for the children. Now, epidemiology. Varicella occurs in 4 to 10 years old age group children with an attack rate of 90% in close contact. About 33% develop shingles at some point in their life, more common among the older people, and children may also get this disease. 50% people living to the age of 85 will have one attack definitely in one's life, and 5% will have more than one attack depending upon the immune status of that patient. Although symptoms can be severe, risk of death is very low because of this disease. Now, etiology. Varicella zoster virus, which is abbreviated as VZV, is a double-stranded DNA enveloped virus. Varicella zoster virus is not same as the herpes simplex virus, but they belong to the same family of herpes viruses. Varicella zoster virus is closely related to the herpes simplex virus, sharing much genome homology. The known enveloped glycoproteins like GB, GC, GE, GH, GI, GK, and GL are like herpes simplex virus, but there is no equivalent of herpes simplex virus GD protein in this varicella zoster virus. Varicella zoster virus also fails to produce LAT, the latency associated transcripts important to establish HSV latency, which go into the latent stage and then reactivate as varicella zoster virus. Varicella zoster virions are spherical and 180 to 200 nanometer in diameter, and here one can see the outer glycoproteins which are GB, GT and GH and GL, and here there is lipid envelope which is covering the whole virus, and then this is the central near central nucleocapsid, and in the center there is double-stranded DNA genome covered by the nucleocapsid, and here these are the just below the envelope there are the viral teguments and the different proteins. Now the lipid envelope encloses 100 nanometer nucleocapsid of the 162 hexameric and pentameric capsomers of the virus. These are arranged in an icosahedral form. Its DNA is a single linear double-stranded molecule. The capsid is surrounded by the loosely proteins called tegument, I have already shown you, which is covered by a lipid envelope having glycoprotein on exterior. These are about 8 nanometer long. These are different, I have shown you in the previous slide. Most people are infected with this virus as children, as chickenpox. Shingles and chickenpox are distinct human diseases, but they are closely related in their life cycle. Both infections are with varicella zoster virus. So here one can see the chickenpox first exposure to the varicella zoster virus, full body rash as one can see in the chickenpox, and I have already given a lecture on this chickenpox. One can go for the more detail in that lecture. Chickenpox is highly contagious, common in children, and it have got live virus vaccine to protect itself. Now, here one can see the rashes on this pattern, the dermatome pattern, and the shingles. It is the reactivation of the varicella zoster virus. There is localized rash. Post-herpectic neuralgia is very common with that. It is commonly seen in people of mostly 50-year-old, and it has got one vaccine which can protect from the shingles like the chickenpox. Now, certain risk factor for this herpes zoster which lead to the reactivation of the dormant virus. These include aging or old age, family history of the disease, poor immune function, immunosuppressive therapy if the patient is having, psychological stress if the patient is having chickenpox before 18 months of age. There is no sex difference. Male and female are equally affected. Black are less prone than the white race, and injury or mechanical trauma can lead to the problem, and exposure to the neurotoxins certain are also responsible as the part of the risk factor. Then surgery can also trigger this problem. Now, it has been said in Canadian Memorial Center for Peace that if you are more fortunate than others, if you are having the more privilege, then build a longer table for the sitting of the people and not a taller fence to avoid the entry of the people. So one should be considerate on this point that build a longer table for sitting, not a taller fence. Now, coming to the pathophysiology of the disease, once chickenpox has resolved, virus remains inactive or dormant for years or decades, reason unknown yet. Now the virus particles switch from their latent lysogenic cycle to the active lytic cycles, reason again poorly understood. Following reactivation, virus travel at a rate of 1.7 to 10 millimeter per hour in ganglia of the spinal cord, in the nerves, in the ganglia of the spinal cord, dorsal root ganglia, or the trigeminal ganglia, or in the cranial nerves. Time to leave ganglia and to reach the peripheral nerves and development of the cutaneous vesicle is about 48 to 96 hours. Virus travels from the ganglia to the nerve ending in the skin, producing the blisters. This varicella virus reactivates and resulting in the shingles disease. So here one can see the nerve cell in the dorsal root ganglia. Here the virus, latent virus, is just residing. As one can see, the virus enter in the body, and from the body it travel to this nerve cell in the dorsal root ganglion, and that ultimately that it reaches to the spinal cord, and viruses move up to the peripheral nerve from the spinal cord, and this is the initial infection of chickenpox or the varicella. Here the virus become latent. Now the virus become reactivated or awakened. The dormant virus which is lying here in the nerve, that become activated and awakened, and that start traveling through these nerves to the nerve endings which are present in the skin surface, and here one can see the rash, the blister, the fluid containing, and then there is a crust formation here, and ultimately the disease ends starting from the rash to the blister, the vesicles, and ultimately the crust is formed, and all it is the latent virus in the nerve cell, and here one can see the dormant virus awakened and reactivated and causing all these skin lesions. Pain is due to the inflammation of the affected nerve plus widespread growth of the virus in those areas. In intact immune system, reactivation of the virus do not occur, and it occurs when the immune system fails to counter these viruses. It can occur at any stage, but mostly age above 50 years or older. Varicella virus in shingles blisters can cause only the chickenpox to the other unvaccinated, but not cause the shingles, because this virus varicella virus has to go into the latency and then reactivate to cause the shingles, and just the virus in the blister can cause only the chickenpox and not the shingle. Virus has never been successfully recovered from the human nerve cells by the cell culture, but detected in autopsy of the nervous tissue. So, no dormant virus in the ganglia of the living people have been detected. So, the how it process occurs is still not very well understood. Now, what are the signs and symptoms? First, the prodromal pain before the appearance of the rash is confused with the toothache and the unnecessary dental treatment the patient do have, not considering that it is shingle. Earlier symptoms include headache, fever, and malaise, which are non-specific symptoms, and it is followed by sensation of the burning pain, itching, hyperesthesia, that is oversensitivity, or paresthesia, pins and the needle feeling, tingling, stinging, pricking, or the numbness that is felt. Pain mild to severe or quick stabs of agonizing pain in affected dermatome sometime. It is limited to one or two dermatomes mostly, innervated by the spinal or the cranial nerves, mostly after 1 to 2 days, sometime after 3 weeks, the rash appear and there appear characteristic skin rash. Shingles in children is mostly painless. So here one can see the spinal cord, the affected nerve, and there is the affected nerve which is having this shingles rash, and these do appear as ulcer, and first they appear as a papule, then they become blisters, vesicles, and ultimately that burst that lead to the ulcer formation. So these are basically papule, blister, and ulcer along the affected nerve path. Now, Zoster sign herpes. It means zoster without herpes. All symptoms of the shingles are there, but there is no characteristic rash. The pain and rash mostly occur on torso, but appear on face, eyes, or other parts of the body. At first, rash appears as hives, but shingle causes skin changes limited to a dermatome, so there is dermatomal pattern which distinguish it from the other diseases with rash. It appears as white stripe or the belt-like pattern limited to the right or left side of the body and never crosses the midline. It means it is mostly unilateral. Most distinctive feature is localization to the dermatome and unilateral distribution of the body. Later, rash becomes vesicular, small blisters filled with a serous exudate. The painful vesicles then become cloudy or darkened, filled with blood, and crust over within 7 to 10 days, as I have shown in my previous slides. Now, this is zoster sign herpes. The patient have all the feature of the herpes, the pain, the crusher, but there is no rash. But common sites of the shingle rash, these are on the back of the head, on this shoulder, back of the shoulder, front of the chest, and here one can see the back of the chest. These are the common sites of the shingle where one can have these. Though rare site also seen, but mostly the most common sites are this. Now, here fever and general malaise continue, then crust fall off and the skin heals, sometime scarring and discolored skin remain. The rash heals Within 2 to 4 weeks, some people develop ongoing nerve pain lasting for months or years that is very agonizing and disturbing for a patient, and that is called post-herpetic neuralgia. Post-herpetic not seen with the shingles in the mouth due to the close relationship of blood vessel to the nerves, virus spread to the blood vessels, and the compromised blood supply causing the ischemic necrosis. In those with the poor immune function, rash may occur widely and it may involve eye causing the vision loss. So here is the development of the shingle rash. On the day 1 it is like this, on day 2 it is like this, on the day 5 it start to have the blister, and on day 6 these are the vesicle. So the symptoms of the shingle and where they develop, first on up to the 5 days they are tingling and burning pain, then rash appears and rash heals and praise gradually go away, and it sometimes remain for months and years as post-herpetic neuralgia. Now the distribution of rash is thoracic about 50 to 60%, trigeminal area 10 to 20%, cervical again 10 to 20%, lumbar region 5 to 10%, and sacral region is less common, less than 5%. But 99% lesions and the rashes are unilateral and they do not cross the midline. And here one can see the distribution in the different area. Here one can see the thoracic area, this area of the thorax is involved, and one can see the front and back of the thorax. Then arms are involved like this, and arm can be involved like this. Similarly, one can have the sacral area or on the buttock, then where it is on the leg, this area is involved. Hands are involved sometime, and here one can see the lesion of the hands. Now, sometime the lesions are on the face and eye. These symptoms develop or dermatome involved. The trigeminal is most commonly involved nerve, especially the ophthalmic region of the trigeminal is involved. When virus is reactivated in this branch, it is termed zoster ophthalmicus. The skin of the forehead, upper eyelid, and the orbit of the eye may be involved. It occurs in 10 to 25% of the cases. Symptoms may include conjunctivitis, keratitis, uveitis, and optic nerve palsies, leading to the chronic ocular inflammation, loss of vision, and debilitating pain in that area. So here one can see when the face is involved, this part of the face, and when the eye is involved with the face, one can see this debilitating lesion, and here also it is involving the ophthalmic branch of the trigeminal nerve and causing the massive problem. Now, if the ear is involved by this disease, shingles oticus, it is called, or it is also called Ramsay-Hunt syndrome type 2. It involves the ear. Here, virus spreads from the facial nerve to the vestibulocochlear nerve, that is the cranial nerve. Symptoms include hearing loss and vertigo. Shingles occur in mouth if maxillary or the mandibular region of the trigeminal nerve is affected. If ophthalmic is involved, then eye is involved. And if the other branches are involved, that cause the shingles in the mouth. Rash appear on the mucous membrane of the upper jaw, palate, or the gums of the upper teeth, or lower jaw, tongue, or the gums of the lower teeth. Oral involvement may be alone or with the skin rash over the cutaneous distribution of the same trigeminal branch. These lesions also only involve the one side, as one can see in the Ramsay-Hunt syndrome. There is facial paresis and the ear lesions are seen. Ramsay-Hunt syndrome, these are when it is involving the ear, and here tongue and the soft palate is involved in case of the other branches of trigeminal nerve.